And as far as the percentage-wise is concerned, the most common valve can affect, we are going to talk about the infective endocarditis. When we talk about endocarditis, can affect any endocardial surfaces, but mostly we talk about the valves. And as far as the percentage-wise is concerned, the most common valve that's involved is 30% aortic valve. After that could be mitral valve at 34% of the disease burden, and then 8% will have both anterior and mitral valve, and 4% tricuspid. So whenever you have endocarditis and any one valve, becomes important to make sure that none of the other valves are involved, but aortic valve definitely takes the most burden of the endocarditis. And then one thing to remember, that abnormal valves will take less virulence to become infected than normal valves. So if infective endocarditis suspicion is high in a patient, it should be higher in patient with abnormal valves. So what about some classic risk factors? So as far as the pathogens are concerned, Staph aureus is actually the most common pathogen. Other pathogens can include streptococci, salmonella, rickettsia, borrelia, candida. If the patients have abnormal or prostatic valves, as I said earlier, or if they have other host risks, which include IV drug abuse, indwelling catheters, etc. Now, the Staph aureus can be present up to 31% of the cases. And then the other thing that I want people to remember, that as far as the streptococci is concerned, you can have viridans, enterococci, bovis. So among the streptococci, the most common is the viridans, which is about 18%. And then you can also have fungal etiology as well, although rare, Haysick organisms, which include your Haemophilus, Actinobacillus, Cardiobacterium, Echinella, and Kingaea. And then you can also have non-infected thrombotic endocarditis. So as far as the clinical presentation is concerned, it could be either acute or it could be subacute. So in cases of acute, these patients can present with fulminant symptoms like acute heart failure. They can present with acute heart block, or they can have acute embolic events. And sometimes when the patients present with subacute, this is when clinically it's kind of difficult to pinpoint. So they can present with constitutional symptoms like low-grade fever or chills. So just something to be mindful. All right, so the way we actually diagnose this is by modified Duke criteria, okay? And the way to remember that criteria is you require either 2 major or 5 minor, or combination of major minor, which could be 1 major plus 2 minor. So if you have 2 major, you're good. If you don't have major, then you have to go through the minor. If you have 1 major, you'll just need 2 minor. But if you don't have major at all, then you'll need 5 minor criteria. You can have new valvular regurgitation or positive echocardiogram results of vegetation, which can include either intracardiac or device mass. Periannular abscess, or you can have new dehiscence of prosthetic valve. How about the minor criteria? So remember we talked about 5 minor criteria. So this is what we're going to talk here. Now these can include fever greater than 100.4. You can have vascular phenomena, and those vascular phenomena can include embolic events, myocardic aneurysm, JNV lesions, or you can have immunologic phenomena, which can include your Osler nodes and then your rod spots, or you can have glomerulonephritis. The fourth one can be your predisposition factors. So those can include previous infective endocarditis history, IV drug abuse, prosthetic heart valve, mitral valve prolapse. Now this one is actually important. So mitral valve prolapse is one of the predisposing factor. You can have congenital heart disease, so that's important. And the fifth one can be microbiological criteria not meeting major criteria. And what was the major criteria that we talked about? That was either they can have coxialbonity with just one positive blood culture, they can have 2 positive cultures separated by 12 hours apart, or they can have 3 out of 3 or 2 out of 4 cultures positive drawn over 1 hour apart. Or they can have serological evidence of typical organisms. Okay, so just to recap, for the minor criteria, you can have fever, you can have vascular phenomena, which can include your embolic events, myocardic aneurysms, JNV lesions, immunological phenomena can include Osler nodes and rod spots, and glomerulonephritis. And the predisposition factors can include previous endocarditis, IV drug abuse, prosthetic heart valve, mitral valve prolapse, and congenital heart disease. Just to touch your JNV lesions. Now these are painless. Septic embolism, septic emboli, splinter hemorrhage are also occur because of the septic emboli, Osler nodes from the word pouch. It's because of Dr. Osler, but anyways, this is painful immune complexes, and then rod spots. These are retinal hemorrhages, but this occurs because of the immunological phenomena. And the other literature that I was reading, it could be 3 minor, not just 2 minor. And I guess the important then question becomes about when should we get the TEE. So if the patients have undiagnostic TTE or non-diagnostic TTE with known or suspected infective endocarditis, or if they have developed complications from infective endocarditis, or they're clinically suspected to have developed complications, or if they have intracardiac leads, that's when you can consider TEE. At the same time, we can also consider TEE in patients who have developed a change in clinical signs or symptoms. For example, these clinical sign changes could be new murmur, embolism, persistent fever, heart failure, abscess, AV block, and also we can consider in patients at high risk of complications. And the patients at high risk of complications, those patients included if they have extensive infected tissue, large vegetation. On initial echocardiogram, if they have staph, enterococcal, fungal infection. On those patients, you can consider repeating the either TTE or TTE. And the definition of the persistent fever is if you have fever beyond 5 days with appropriate antibiotics. On the other hand, TEE should be considered in patients who are undergoing surgery, and so in those patients, intraoperative TEE is recommended. Now, another thing to consider TEE in patients who will undergo change of antibiotics early on from IV form to oral form. Now, what you do in these patients is that you get a baseline TEE before oral therapy, and then you get TEE at 1 to 3 days before completion of therapy to determine the resolution of vegetation, usually at a 2-week mark. Now there are some class 2A recommendations to do TEE, and that is to do in patients with staph aureus bacteremia without known source. And the other 2A recommendation for patients to maybe consider performing a TEE in a patients with prosthetic valve with persistent fever without bacteremia or a new murmur. So these are two class 2A recommendations to consider performing TEE. Now changing gears, but still talking about the class 2A recommendations, if the anatomy is not clear on echo, then one can consider CT imaging, especially in the setting of suspected paravalvular infection. And then another class 2A recommendations are if the patients have possible infective endocarditis by Duke's criteria, then one can consider combination of PET and CT as an adjunct diagnostic modality. Again, this is also a class 2A recommendation. Now, a 2B recommendations are if the patients have nosocomial staph aureus with portal of entry from extracardiac source, the TEE might be considering those patients to detect staph infective endocarditis if clinically indicated. Okay, so if the patients have suspected or at risk infective endocarditis, the class 1 recommendation is that you do for these patients is we get the blood cultures, we use the modified due criteria, and of course we'll get heart valve team involved. First thing that we try to do is that we get the TTE, and then when would be considered TEE, other imaging modality, just to summarize. So if the TTE is non-diagnostic, or if there is infective endocarditis complication suspected, or if there are intracardiac leads present, then you will consider TEE. Or if there is infective endocarditis with change in signs or symptoms, if there is high risk of complications, or if there is microorganisms which can include Staph aureus, enterococci, or fungal infections. Or, as we have discussed earlier, all of these things we have discussed earlier as well, or if the patients have stable infective endocarditis being considered for change to oral antibiotics. And all of these patients, you can consider TEE, and this is a class 1 recommendation. If the patients are undergoing valve surgery, then it's also a class 1 indication for TEE. Now, as far as the class 2 indications are concerned, if you have Staph aureus with known source, or there is a prosthetic valve with persistent fever without bacteremia or new murmur, those patients we can consider 2EE, but remember this is going to be the class 2A recommendations. Other class 2A indication is to get the cardiac CT, and we consider cardiac CT if the echo images are not adequate with suspected paravalvular abscess. And then we can also consider FDG PET-CT in patients who have possible infective endocarditis by modified due criteria. In those patients, you can consider FDG, PET, and CT. And the last but not the least, which is the class 2B recommendation, and that is to consider TEE in patients who have nosocomial Staph aureus, bacteremia with known portal of entry. In these patients, you can consider TEE to rule out infective endocarditis. Okay, so now we are going to talk about the treatment and the surgery for infective endocarditis, and based on the recommendations. So if there are patients with infective endocarditis, a class 3 harm that I want to talk about is that if the patients have valvular heart disease with unexplained fever, they should not receive antibiotics without blood cultures. So just because they have a valvular heart disease and they have unexplained fever, they should not be started antibiotics without getting the blood culture first. So that's really important. If the patients have infective endocarditis, of course, the class 1 recommendation is to do the antibiotics treatment with ID consultation. And then after you start the patient with antibiotics, the decision about the surgical intervention should involve heart team approach. All right. And then what are the conditions in which one will consider the early surgery? So the conditions, the class 1 indications for early surgery include valve dysfunction causing heart failure symptoms, or if the infective endocarditis is caused by Staph aureus, fungal infection, or highly resistant organisms. Or if the patients have complications of heart block, if they have annular or aortic abscess, or if they have penetrating lesions, or if they have persistent fever, which is they have bacteremia, or persistent infection, which can include bacteremia or fever for greater than 5 days on antibiotics regimen. If they have any of these things, then this is a strong class 1A recommendation for valve surgery. Okay, so the other class 1 recommendations otherwise is if the patients have infection in their endocardic devices, then of course one should consider complete removal, generators and leads. Other than that, if the patients have prostatic valve endocarditis with relapsing infection, consider surgery. Other class 1 indications, and this will be all going here, if the patients have recurrent endocarditis with continued IV drug abuse, then in these patients, one should have ethics team involved, so a consultation for discussing the long-term prognosis should be considered before repeating surgical intervention. Now we'll talk about some class 2A recommendations for consideration of the surgery. So if the patients have recurrent emboli or persistent vegetations despite being on antibiotics appropriately, in these patients you can consider early surgery. It is a class 2A recommendation. And then as far as the weaker recommendations, which can include your class 2B recommendation, which is if the patients have large vegetation, which is greater than 10 millimeter and is mobile, then you can consider early surgery. But just the size itself shouldn't be the reason, so that's why there's a weaker recommendation of 2B. And how about if the patients develop major ischemic stroke or intracranial hemorrhage? Now in these patients, you can consider delaying surgery for greater than 4 weeks. The other thing that I wanted to talk about was if during the acute phase where the patients have developed infective endocarditis and they've developed then infective endocarditis with cerebral embolism or stroke. So what to do with those patients in terms of the anticoagulations? So in these cases, the class 2A recommendation is to temporarily discontinue all anticoagulation, temporary. But if they do not have infective endocarditis with cerebral embolism, then the class 2B recommendation is to still consider discontinuing temporarily all anticoagulation. So if the patients have infective carditis with cerebral embolism or stroke or without, consider temporary discontinuation of the anticoagulation. The other thing that I wanted to point out is, again, with the class 2B recommendation, so if the patients have infective endocarditis and if they have stable left-sided infective endocarditis after initial antibiotics, then you can consider in those patients changing to oral therapy after performing TE. So that is something to consider. So the bottom line in these patients is the early surgery should be considered in patients who have heart failure symptom, those patients who have highly virulent pathogens like Staph aureus, fungal infection, or highly resistant organisms. If the patients have heart block, annular aortic abscess, or penetrating lesions, or if the patients have persistent fever or persistent infection in the form of either persistent fever or bacteremia, which is in cases for greater than 5 days on antibiotic regimen. In those patients, you should consider early valve surgery. And if patients develop infective endocarditis with or without cerebral embolism or stroke, consider discontinuing all anticoagulation temporarily.